some relatives who have undergone topical anesthesia. Sometimes patients come to us. They may be a very suitable case in terms of anatomy, but if you look at the patient nature, they might have a like very strong bells, and they might start squeezing on table. So in the pre-operative counseling, you have told, okay, I'm going to do a topical anesthesia, but on table you realize that it's not possible. Patient is squeezing really hard, and there's a strong bells. So you have to anyway inject subtenons, I think, to be on the safer side. So how will you counsel at that time? Dr. Manju, you want to say something? Sorry.
So we can very well tell the patient, yeah, if you're not able to look at the light, so while lying under the microscope, you'll have great difficulty. So that will lead to more complications. And so it is better, you can give the choice. It is better to do under block. It won't be very painful. You have to counsel the patient properly and give them confidence. Like it won't be much painful. It'll just will have the pain of the injection, that's all. And you'll have to talk to the patient continuously while giving block. See, what you have done is some of the patients, they pre-operative will tell, okay, doctor, I'm very anxious like that. If that is the case, then we can take precautions. What I always tell the anesthetist, please keep a paraffin soft cotton tip applicator here. That Kuchi is Dana Johnson's, but so we soak it with paraffin and then just keep on the skin where we are first pricking. So then the initial prick, there won't be any pain for the patient. So after that, we inject little and wait for a while and then inject further. So most of the, and if you continuously talk to the patient, I think patients will cooperate, even for block, topical, whatever it is. But if the patient is very anxious, if they are choosing topical anesthesia because they are very scared of pain of injection, then don't operate under topical anesthesia, because they won't cooperate during the surgery. And few things is, yeah, the talk was excellent talk. And then few things are, selection of patients are very important. Like don't take complicated cases, don't take very hard cataracts or mature intumescent lenses. So that depends again on surgeon's confidence. But as a general rule, you should not take very difficult cases when you're operating under topical anesthesia. And high myopes, especially because the risk of clot perforation is high. So it's better to operate them under topical anesthesia. But again, because the scleral rigidity is low, when you're entering the eye with the infusion, normal infusion pressure, then there'll be stretching of ciliary body, what is known as that CBDSO. They'll have pain. So always supplement with intracameral 1% preservative-free lidocaine when you're operating under high myopes, because of the ciliary body stretching, they'll have more pain. And another tip is, if you're operating, instead of putting BSS, you can put OVD over the cornea, so that there is no need of frequent irrigation of the cornea with fluid, because that is the time the patient squeezes the eye. So OVD can be put. And another tip is, while doing this, the hydrodissection should be complete, because when you are rotating the nucleus, this ciliary sonules, they'll produce some tug on the ciliary body, and that can cause pain. So hydrodissection should be very good, and the nucleus rotation should be gentle. And always operate with, don't overinflate the chamber with OVD, because that will cause the high pressure and then deepening of anterior chamber. So or underfill the anterior chamber with OVD. So these are some of the tips when you are operating under topical anesthesia. And anytime if the patient complain of pain, you have options of injecting subconjunctival xylocaine. You can give subtenants. All these options are there if need arise.
And one more point is, when we are counseling the patients, we should tell them, though you have opted for a topical, depending on the situation, we might have to supplement you with additional ocular anesthesia. Like you might need an injection during the surgery, because sometimes when we counsel on table, it will become a surprise for them. So next I call upon Dr. Sandhya to present her topic on toric IOLs. Dr. Sandhya is a senior cataract surgeon practicing at Giridhar Eye Hospital, Kochi.
So toric IOLs in cataract surgery, how to optimize outcome. So aim of modern cataract surgery is to give maximum free spectacle free vision to the patient, and not just removal of cataract. So around more than 40% of cataract population have a cylinder of more than 1 diopter. So not addressing this during cataract surgery will cause patient dissatisfaction. So now we have toric IOLs to correct up to 4.75 diopters of corneal astigmatism. So proper patient selection and acquisition of accurate preoperative patient data and precise IOL calculation and execution of proper surgical plan are critical to optimize toric IOL outcome. So suitable candidates are patients with regular corneal astigmatism of more than 1 diopter. Nowadays we are correcting smaller and smaller amount of astigmatism. So the first patient has regular with the rule astigmatism and the second patient there has regular against the rule astigmatism. So dry eye and ocular surface conditions should be treated before taking keratometry measurements. Now with the advent of optical biometers, accurate axial length measurement is not a problem. But measuring cornea is the major problem in IOL power calculation. So we have to take these precautions. We have to treat the dry eye and ocular surface before measuring cornea. And patients with epithelial basement dystrophies and irregular corneal astigmatism, they should be avoided for toric IOL implantation. And high myopes are not good candidates, and you should have an intact capsular bag to provide rotational stability for the IOL. And you should measure the cornea before putting any dilating or anesthetizing drops. You should avoid drying, pressing, or rubbing of eyes. And you should take consecutive identical readings with good signal strength. And you should always avoid measurements with those warning signs. And you should also look at the Myers. If the Myers are missing or irregular, you should not take readings corresponding to that. The subjective refraction should not be taken for toric calculation because it includes lenticular astigmatism, so that is going to be removed during cataract surgery. So this patient with severe dry eye, and she was a rheumatoid arthritis patient, and she had a visual acuity of 636, best corrected visual acuity, and she was planned for a toric IOL. And her ocular surface was looking like this. And then after 3 days after punctal cautery, the cornea ocular surface improved and her vision improved to 6.9. So this shows the importance of treating ocular surface before cataract surgery. And whenever you should repeat the measurements if there is inconsistency between measurement, and if the steep axis is more than 47 diopters and the flat is less than 40 diopters, and if there is high astigmatism of either eye of more than 2.5 diopter, and also if there is asymmetry between the eyes of more than 1 diopter. So topography is helpful in ruling out irregular astigmatism. Now that we have identified the suitable patients and we have taken accurate measurements, now let's move on to IOL power calculation. So basically cornea has both anterior and posterior corneal astigmatism, and anterior cornea has with the rule astigmatism and posterior cornea has against the rule astigmatism. So if you don't address the posterior corneal astigmatism, that will lead to overcorrection of with the rule and undercorrection of against the rule astigmatism. Some of the newer optical biometers and manual keratomies and a topography based system, they measure only the anterior cornea. So why is it important to measure the posterior cornea? Because of the concept that if it is not corrected, the with the rule astigmatism will be overcorrected and the against rule will be undercorrected. So some of the newer biometers, optical biometers like IOL Master 700, it can measure the posterior cornea also. So coming to IOL power calculation, the most widely used formula is Barrett toric calculator. So this is available free online in ASCRS and APSCRS website. So what you have to enter is, you have to enter the K readings, you have to enter the axis of the K and then the incision location and the surgically induced astigmatism. Then it will measure and give you the IOL power that is needed. And also it gives the axis of alignment of the IOL. And so it also gives the message of residual refraction if you place this IOL in the eye. Now the significance of surgically induced astigmatism is coming down because the incisions are becoming smaller and smaller, and also because of the concept of centroid, this was assigned a value of 0.1 diopter. So if the patient is choosing a premium IOL, what he can do is, inside the optical biometer itself, this Barrett toric calculator formula is there in most of the biometers, Lenstar, IOL Master, etc. So you can put it directly into toric calculator. So if there is astigmatism and toric IOL is needed, it will give a print like this. So it will give the power of the IOL and alignment of axis, etc. And if no toric IOL is needed, it will give a message that not appropriate lens model found. So in that case, you don't have to put toric IOL. So if you get like this, you don't have to think about against rule astigmatism, with the rule astigmatism and all those things. You can straight away send the patient to counsel for toric IOL. And this toric IOL has some marks here that should be aligned with the steep axis of the cornea. And coming to the surgical plan, so these are the things that need to be done in addition to what is being done in a normal phaco. That is, you have to do reference marking. That is, the 0 and 180 should be marked, and this should be in the sitting position to take care of cyclorotation. And then you have to mark the steep axis of the cornea, because the IOL has to be aligned in that axis, and then the IOL mark should be aligned with the steep axis of the cornea. So these are here I am using a bubble marker for reference marking. So when the bubble is center, you have to mark the cornea at the limbus as shown here. So then it will be 0 and 180. The bubble should be in the center. Now in this, it's a slit lamp based method. So the beam is rotated to horizontal position. And when the Purkinje image is ask the patient to look straight, and the Purkinje image is when in the center, you have to mark the cornea when it touches the limbus. Now this patient is lying down under microscope after reference mark. You can see here. So you should mark the cornea and not the limbus, because not the conjunctiva, because conjunctiva is mobile, and the rexus should be round, and it should uniformly overlap the IOL so that the IOL position remains stable. And then the clear corneal incision should be very smooth without any ragged edges. And then rest of the things are normal. You have to do a hydrodissection, and the phacoemulsification is like a routine phacoemulsification. And when you are marking the cornea, you should avoid spreading of the dye and smudging, etc. And once the nucleus and the cortex is removed, the eye was filled with OVD, and then you have to mark the axis. That is the degree gauge on this ring is aligned with the 0 and 180 marks. Here the axis is 165 and the steep axis is marked like this. Now the toric IOL is slowly injected, and you have to rotate it clockwise as it unfolds, and you have to stop around 3 to 5 degrees short of the final desired axis, somewhere around 5 to 10 degree. And then you have to unfold the haptics completely so that it settles down well. And then you have to remove the OVD first from behind and then from above the lens, and then finally align the lens to the axis that was previously marked. And then you can just tap the lens onto the posterior capsule so that it remains stable.